Yes, Dr. Noor, you have 15 minutes for long consultation. You have to take history, examine the patient, and address his concerns. So let's start now.
Good evening.
Good evening, Doctor.
Yes, I am Dr. Almardi, doctor on acute medical unit today. Are you Mr. Somar, 50 years old?
Yeah, I am Somar, Doctor.
Yes, nice to meet you.
Thanks.
Good. Mr. Somar, we are here to discuss some issue related to your health status and examine you and answer your concern. It is okay for you?
Yeah, please, Doctor.
It came to my knowledge that you are being troubled with tummy pain. Can you tell me more about this?
Yeah, Doctor, I have been suffering from tummy pain for 1 week. It started suddenly and then increased in its severity.
Yeah, sorry for that. Is it present all the time or on and off?
No, Doctor, it's all the time.
Yeah, this first time you have this pain or
Yeah, it is
you have
it is the first time, Doctor.
Yeah. Where is the side exactly in your tummy?
It located at the upper part of my tummy, Doctor.
Yeah. Uh, yes, in the upper part.
Yes.
Yeah. What does look like this pain? It is look like a dull or sharp pain or
Yeah, it looks like sharp
pain,
pain, Doctor.
sharp pain. Yeah. If you give you a score from 1 to 10, 10 is the maximum. How you can score it?
It's now a 10 by 10, Doctor.
Sorry for that. Can I provide you with any painkiller now?
Yeah, they have already given me painkillers in the ER, Doctor.
Okay. This pain, it is go anywhere way in your tummy.
No, no.
Yeah. It is associated with any feeling sick.
Yeah, Doctor, I'm feeling sick also. I throw up many times.
Yeah. Yeah. This pain, it is related to your food when you took food. Or,
No, no, but I have no appetite, Doctor, to eat.
yeah. Do you have any difficulty of swallowing?
No.
Yeah. Any lost motion?
Yeah, Doctor, I have loose motion for 3 days.
Yeah. It is watery or well formed.
No, Doctor, it's only loose, Doctor.
Yeah. It is difficult to flush.
Yes.
It is pale.
No.
Yeah. It is offensive.
Yeah.
Yeah. It is containing blood or mucus.
No, Doctor, it looks like greasy stool.
Yeah. Uh, do you have any constipation before
No.
this motion?
No, no, I have normal motion before that, Doctor.
Yeah. Do you have any past medical if not
Yes, Doctor, I have diabetes and hypertension.
diabetes? It will control.
Yeah, it's good, Doctor. It's accepted.
Yeah. Yes. What is the last reading of 3 months?
Yeah, the last HbA1c, Doctor, was 8.
Yes. Are you compliant with your medicine?
Yeah, I'm trying, Doctor, to be adherence.
But about your diet, exercise?
Yes, I'm trying the best, Doctor.
Yeah. About any attack of low blood sugar?
No, no, no blood sugar. No low blood sugar.
Uh, do you have any change in your water, in for amount or color?
No, no,
Any
no,
any frozen water?
no.
Uh, any color of vision?
Blurred vision? Actually, Doctor, I underwent a laser therapy 1 year ago because I have some blurred vision. I had some blurred vision that time.
Yeah. Okay. Do you have any weakness?
No weakness.
Any pins on abnormal sensation? Pins on the
Yeah,
foot?
I'm feeling numbness in my feet, Doctor. Yes.
Yeah. Do you have any difficulty from sitting to standing position?
No.
Do you have any change in your weight?
My weight is stable, doctor.
Yes. Any high temperature?
Actually, doctor, I'm feeling hot, but I did not check my body temperature.
Yes. Any sweating, light sweating?
No.
Yes. Do you have any cough?
No.
Any short of breath?
No.
Any awareness of heartbeat?
Yeah, I'm feeling that my heart beating fast, doctor.
Yeah. Any lower leg swelling?
No.
Yeah. Do you have any history of travel and recently?
No.
Yeah. Can I know what is your medicine you take?
I'm taking lisinopril, doctor, 10 milligram a day, metformin, 500 milligram twice a day, glycoside, and Victoza, 1.2 milligram a day.
Last one, what?
Victoza.
Okay. Any recent change in your dose?
No.
Yeah. Okay. Where do you have any hospital admission before recently?
No admission recently.
Yeah. Do you have any where you stay?
I'm staying with with my wife, doctor.
Yeah. Any similar condition in your family?
What I can remember that, doctor, my father, he was suffering a lot of pain like me, doctor, and they told him they have stomach cancer. And also my brother, doctor, has stomach soreness.
Okay. Uh, and change my water. Do you have any past history of surgery?
No surgery before.
No surgery. Do you have any headache?
No.
Uh, any abnormal weather intolerance?
No, doctor. No problem.
Can I examine you?
Yeah, please, doctor.
Yes. Examine the hand.
Yeah, what you are
Above.
looking for in the hands, doctor?
Yes, in the hand. Any deformity?
There is no deformity,
Yeah. Any nail change?
no nail changes,
Yeah.
like a clubbing. So you are looking for clubbing in this patient. Yeah, there's no clubbing.
No collabing. Any joint pain or skin rash?
No rash.
Joint pain?
No, I have no joint pain.
Yeah. Any tight skin?
The skin is not tight.
Yeah. The pulse rate bilateral?
Yeah, so you have to check pulse in both hands. You are right, very good. So you see that pulse that could be the patient could tachycardic or could be normal sinus pulse, equal in both hands with normal volume and normal characters.
Yeah. Any postal hypertension?
Yeah, you can ask the examiner that I want to check the blood pressure in the supine and standing, no drop.
No drop. Any jaundice? Any pale?
Yeah, not pale, also not icterus.
No. Any mouth ulcer?
There's no oral ulcers.
Yes. Any lymphadenopathy?
Yeah, so you have to check if the patient has any cervical, supraclavicular, is right?
Yeah.
It's very important in this patient to see also to check supraclavicular. Okay, so no lymphadenopathy.
Yeah. Examine the abdomen. Any
Abdomen
tenderness?
tenderness. Yes, there's epigastric tenderness.
Yeah. No mass?
No masses.
Any organomegaly?
No organomegaly.
Any lower leg swelling?
No lower limb swelling.
Mr. Somar, do you have any acid test in your mouth?
No.
No. Do you smoke?
Yeah, I'm smoking.
How many cigarettes for how day?
Actually 10 cigarettes a day, doctor.
Yes, I advise you to stop smoking because smoking is affect your general health. If you didn't
Okay,
mind, I
doctor.
will to incubation and to cesarean clinic sedation.
Okay,
Do you
okay.
drink alcohol?
Yes, I'm drinking.
How many units per day?
Actually, I'm taking alcohol daily, doctor. It's about 2 glasses of wine.
2 glasses. On the weekend?
Yeah, sometimes more, doctor. Sometimes more in the weekend.
Yeah. Do you feel any? Do you feel to cut down?
I'm not taking so much, doctor. It's only 2 small glasses, doctor.
Small glasses. Yeah. Do you eat any food from outside?
Sometimes, doctor, sometimes.
Yeah. Yes. Can I notice your concern?
What I have, doctor? I'm afraid that this could be stomach cancer like my father.
Yes, I appreciate your concern, and from what you tell me, and after examining you, the cancer is was a possibility, but it is lower as you have no symptom suggestive of the cancer, but it should be excluded.
So
Uh,
what could be, doctor? What could be the cause of this severe pain?
uh, Actually, I didn't find any cause for this. Might be infection, or might be we will do for admit you, and we will do for you some blood test imaging.
So is there anything serious, doctor? Please reassure me, doctor. I'm sorry.
Yes, actually, it is this has been serious, but will be
Two
excluded
minutes.
serious in this condition.
So could be stomach soreness, doctor, like my brother?
Yes, this might be one of possibility.
Mm. So could I need a camera test?
Uh, Camera test, no indication now for this camera test, but we will do for you some test, and after that we discuss.
Yeah. Okay. Okay, doctor. Thank you. It remain 1 minute, doctor.
Yeah.
Okay. Thank you very much, Dr. Noor. Thank you. Thank you for trying. So you have to practice more. You have to training more. You have also to follow a specific approach for each symptoms to be fluent. To be fluent. Also, you have to be systematic when you take a history. That is very important. So you have to be organized by history. Start by the presenting symptoms. Do full analysis of the presenting symptoms. Then you have to go to the presented system that I will mention now in details to the involved system. You have to ask in details for other symptoms related to this system. Then you have to go to the differential diagnosis. So already you have to put a differential diagnosis outside. And when you go inside, you have to try to confirm or exclude it. Then you can go to the systemic review. Systemic review is important and essential that can help you sometimes to get a diagnosis. Then you can go past medical history, past surgery, medication, family history, social history. So it's the way that you can guarantee full marks. Believe me. And this is the way that can help you to get the diagnosis. If you follow this systematic way, this could help you to get a diagnosis. So what the diagnosis you get from this case, doctor?
Yes.
But what are differential
Might be
diagnoses of epigastric pain in general?
acute.
Yeah, what differential diagnosis of epigastric pain? Acute, yes, or chronic, whatever.
Maybe gastritis or gastric ulcer.
Yeah, could be gastritis, could be gastric ulcer. What else?
Might be duodenal ulcer.
Yeah, could be also. I agree with you. What
Yeah.
else?
Might be might be acute pancreatitis.
Yeah. Why don't think about this diagnosis? Why didn't you think about this diagnosis? So what I should ask to be sure that it's pancreatitis? What
Yes.
are special characters of pancreatitis, of pain in patient of pancreatitis?
This is related to the food.
There's something more characteristic. You see, you asked me, doctor, does this pain affect other parts of tummy? When you ask me for radiation, but you did not ask me whether this pain radiate to the back, and it's a critical question. So it's very important. So you have to ask the patient, does this pain radiate or spread to your back? Yes, doctor. Also, position. We know that pain in patient of acute pancreatitis, whatever, acute or chronic, related to the position. So the pain could increase when the patient bending forward and improve when the patient in the supine position. Is right? So this is also very important to ask. Also, doctor, how can get the diagnosis? I will tell you I will ask you the questions in different way. How can sometimes get the diagnosis of peptic ulcer disease? Regardless the character of pain and the sign of pain. If the patient presented with abdominal pain and you find in the history something, it can guide you that it's peptic ulcer disease. What is it?
Related to the food.
No, regardless the character of pain. Regardless
Yeah.
the character of
Anyway,
pain.
any hemoptysis.
No, when you have patient has risk factors of peptic ulcer disease, so I should suspect peptic ulcer disease regardless the character of pain, because we know that in medicine, nothing could sometimes, it's not necessary for peptic ulcer disease to be presented with the classic manifestations. So if I have patient of abdominal pain and the history revealed risk factors for abdominal pain, like patient take NSAIDs, patient take aspirin, so I have to suspect that, is right? So also in the same way that for pancreatitis, when I should suspect that this patient could be pancreatitis, also when the patient has any risk factors of pancreatitis. So what are risk factors of pancreatitis in our patient?
Alcohol.
What else? Great, Dr. Ahmad. Dr. Ahmad answered you that Victoza. Really, it's an interesting case and difficult case appeared in the DAC 3 2023. So it's a new scenario appeared recently. It's Victoza-induced pancreatitis. This is the diagnosis. So this is the diagnosis in this case. So the patient has a pain consists with pancreatitis. The history showed that the patient taking Victoza and the patient has another risk factors for pancreatitis that it's alcohol, but Victoza is a direct cause of pancreatitis. Why? First, you have to ask the patient when he started this medication. He will tell you that I started only 3 months ago. And also, if you see that he's not alcoholic, and two glass of wine, doctor, small glass of wine, it's not a large amount. It's only equal to 15, 16 units, not more. Okay. So the next question, doctor, differential diagnosis, what could be? Victoza also can cause peptic ulcer disease. So Victoza can cause peptic ulcer disease. So what the name of Victoza? It's liraglutide. Liraglutide. So here the diagnosis liraglutide induced pancreatitis or could be induced peptic ulcer disease, or the patient has also Helicobacter peptic ulcer disease, especially that this patient had a family history of peptic ulcer disease. He told you that my brother has stomach soreness. Could be. We know that usually Helicobacter really, it's common in other family members. It's common for the other family members to have Helicobacter induced peptic ulcer disease. It's really very common. So this could be the differential diagnosis in this patient. Next questions, what are investigations you will request, doctor?
Yes, apart from basic investigation, blood count, ESR, seroactive protein, renal function test, electrolyte, and liver function test. I will do for him lipase and amylase
Yes.
and serum calcium.
Mm.
I do
Why
for
serum
him
calcium, doctor? Why? What the indication? You are right, but why?
might be cause of gas.
Because hypercalcemia can cause both pancreatitis and peptic ulcer disease.
The ulcer disease. Yeah.
Yeah. Okay, what else you request?
I do for him a stool general culture. I do for him endoscopy or MRCB or ARCB or CT scan.
Yeah, so I will do abdominal ultrasonography first, endoscopic ultrasonography, abdominal CT, ARCP, MRCP, you are right. But other blood tests that should be requested in any patient suspected of pancreatitis.
Arterial blood gases.
Yes, yes. It's a
Blood.
routine test for all patients suspicion of pancreatitis. So APG, and serum lactate dehydrogenase, LDH, and bicarbonate. Also, doctor, it's very important to do serum cholesterol and triglyceride. We know that some people could develop pancreatitis if triglyceride is high. And also for autoimmune pancreatitis, you have this ready, it's written that routine tests will be done. For autoimmune pancreatitis, we have immunoglobulin G4 that could elevate it in autoimmune pancreatitis. So these are the blood tests that should be requested for any patient. Yes, you are right. Very good, Dr. Ahmad. Really, really, Dr. Ahmad mentioned something very good also. Yeah, blood sugar, it's very also important because this is one of the important indicator for severe pancreatitis if the patient has hypoglycemia. So these are the most important electrolytes, as we have mentioned. All electrolytes should be requested, especially sodium, potassium, calcium. That's very important. Yeah, next question, doctor. How can manage this patient?
Yes, admission.
Yeah.
Stop depending drugs.
Okay, very good. What else?
Yeah, fluid replacement. analgesic.
So let's, Doctor, it's better when the examiner asks you this question to start by answering that non-pharmacological, pharmacological. Why this important? This can also help your brain to remember the measurements, non-pharmacological measurements that is very, very important. They like it. They like to mention something non-pharmacological, believe me. So non-pharmacological. So first of all, this patient need hospital admission. Great. This patient need hospital admission. Then what are non-pharmacological measurements in this patient? Stop the offending medication. What else?
Multidisciplinary team.
Yes, patient education, counseling, multidisciplinary team. Yes, what else? Patient of pancreatitis. Tell me what you are doing in the hospital.
Close monitoring.
Yes. What else?
Replacement fluid.
Yeah, fluid resuscitations. What else?
Analgesic.
Before non-pharmacological.
Non-pharmacological.
Nutritional support, MPO.
Yeah.
Right? So this is what you can do first. So this first measurements, non-pharmacological measurements. Also in our patient, doctor, counsel the patient about alcohol. This patient should reduce the alcohol amount to recommended amount. That's 14 units. Now, of course, not now. Not now. It's advised to stop alcohol drinking. But when the patient improved and discharged from hospital without any complication, so that time you have to counsel him. So this you can mention it in the also non-pharmacological treatment. Also smoking cessation. Please don't forget, believe me, they like it. And they put mark for that. They put marks for that. And also smoking cessation because the patient is smoking. So I should mention now stop alcohol drinking. Okay? Yeah. Then pharmacological.
Pharmacological antibiotic.
Yeah. Is it routine? You have to use antibiotic routine for all patients with acute pancreatitis.
No.
So what are indications for antibiotics in patients of pancreatitis? Yeah, antibiotics should be used in any case of pancreatitis complicated by infected pancreatic necrosis, but should not given routinely for fever, especially early in the presentation. So if the patient has complicated pancreatitis with infected pancreatic necrosis. Otherwise, really, the use of antibiotics in severe pancreatitis controversial or controversial, it's not confirmed. So it's not recommended recently, okay? Currently is not recommended. So here, that supportive treatment, as we have mentioned, fluid resuscitations, nutrition support, analgesics, like sometimes we need to use opioids for antibiotics that indicate only in severe cases. Yeah. Thank you very much, Dr. Noor. Let's me explain the approach now of abdominal pain.
Thank you.
Yeah, thank you very much. So first of all, let's discuss how can approach a patient in this long consultation, regardless our scenario today. So this picture, I upload it every time. That can help you to take a systematic history that's very important and can help you to get the diagnosis. First of all, Royal College will give you 5 minutes outside to prepare for this long consultation. So what I should do outside? How can you use this time outside? First of all, read the scenario carefully to know what's your task. What are vital signs? Because they will give you vital signs outside. And what I advise you in your paper outside, Write the patient name, so we can upload the scenario again. Yeah. So in your paper, write the patient name. So I have patient, Mr. Sommer, 50-year-old man. Also in your paper, write, please, write like that, abdominal pain. And beside it, write for examination. Later on, I will tell you why. So write abdominal pain and write beside it examination. Then down, write abnormal vital signs. If there's any abnormalities in the vital signs, you have to write it in your paper because it considered abnormal sign. If the examiner asks you what are abnormal signs, so you have to mention any abnormalities in the vital signs. Let's agree for this basic rules. So write the patient name in your paper, write the main complaint, and write beside it for examination, then write the abnormal vital signs only. Then what I should do, I should write my differential diagnosis. Sorry. So then I will write the differential diagnosis. This is what I will do outside. So what are differential diagnoses of abdominal pain in the emergency department? In general, I will write what could be the differential diagnosis of abdominal pain, and I will try inside to confirm or exclude it. Now, when you go inside, introduce yourself. I'm Dr. Hassan. I'm a doctor in the acute medical unit. I'm a doctor in the nerve clinic. I'm a doctor in heart clinic, whatever. Confirm the patient ID. Can I confirm that you are Mr. Sommer, a 50-year-old? Yes, doctor. I'm Sommer. Ask for permission. Mr. Sommer, we are here to talk about your health condition and examine you. Is it okay for you? So you have to tell the patient what's your agenda and take permission for that. So we are here to discuss about your health condition and examine you. Is it okay for you? Yeah, doctor. Confirm the privacy. Then start with an open question. So you have to start with an open questions. So tell him that, Mr. Sommer, it comes to my knowledge that you have suffering from tummy pain. Is it right? Yes, doctor. You can tell me in more details about that. Also here, listen to the patient carefully. The patient could mention something very important. Can mention for you that this tummy pain, when started, how it started, whether it's intermittent or progressive, he can mention to avoid to ask him again about that. So you have not to ask him again for this information. So as we have mentioned, you have to start with an open question. Then after that, you should be the master. You should ask the patient closed question. So you can start with an open question, then you can go to the closed question. So then you have to do full analysis of the presenting symptoms. You have to ask in details for these presenting symptoms. In our scenario, it's abdominal pain. So ask the patient for onset. When it start, how it start? Does it start suddenly or did it start suddenly or gradually? Then the disease course. Is it intermittent or persistent pain? If the patient has intermittent pain, you have to ask him how frequent do you have this pain? How frequent do you have this pain? And the duration, how long each episode of this pain lasts. So onset, course, duration can be applied for any symptoms. Then ask the patient that it's the first time you have this pain or have previously had similar pain. Then for any pain, regardless the site of pain, back pain, joint pain, headache, chest pain, you have to ask in details for this pain, for its site. You can show me, ask the patient, you can show me where the pain exactly. The patient in our scenario can see that it's in the epigastric area. So the site of pain, then radiation. Ask him, Does it spread to affect other area? And give him example. Does it spread to your back? Does it spread to other parts of your tummy? So you have to give example. 3, the nature of pain. Give him also example. Is it a colic pain? Is it a dull ache pain? Is it a sharp pain? Let the patient choose. Then severity. Give the patient a scale from 1 to 10 to choose that 1 is a minimum pain while 10 is a maximum pain. So it's very important, and this a red flag of pain. You see, the severe pain is a red flag of pain, is right? So you have to ask about this one. Then provoking factors, improving factors. Also, you have to give the patient examples. So how can know these examples? How can know what I should ask as a provoking factors? Your differential diagnosis. So provoking factors, you can put in your mind that this could be peptic ulcer disease. So I can ask the patient, is there any specific food can make your pain worse, like spicy food? You see? I put in my mind that this could be pancreatitis. So is there any specific position can make your pain worse, like when you bend forward, you see? So according to my differential diagnosis, I can know what are the provoking factors. So it's better to give examples because the patient could not aware for that, Also, any certain medication, any certain food, you see? Then for improving factors, also give the patient example. Anything in particular can make the pain better, like painkillers. So some patient of peptic ulcer disease could take painkillers like NSAIDs, and this can make the pain worse, right? So patient that time he will tell you, no, doctor, painkillers make the pain worse. So that time you know that this could be peptic ulcer disease. Patient of pancreatitis could not get benefit from simple analgesics, right? If the patient of pancreatitis take paracetamol, could not get any benefit. So he will deny any improvement with painkillers. So also give examples, okay? Any certain position, the patient of pancreatitis could get better when lying on the bed. Then time, especially nocturnal pain. Nocturnal pain, whatever the site of pain, consider a red flag of pain. It's a rule. It's a basic rule. Any nocturnal pain, consider red flag of pain. Nocturnal headache, nocturnal back pain, nocturnal chest pain, nocturnal abdominal pain. So ask the patient, does this pain prevent you to sleep? Do you wake at night feeling this pain? You see, does it prevent you to sleep? Also ask the patient if there's any particular time you feel that this pain is more. So this for night pain and in general, any specific time. Then I will go to ask the patient for associated symptoms. Also, it's different from symptoms to other. If I have patient of abdominal pain, I should ask the patient if there's any nausea, vomiting, change in the bowel habit. It's right. If I have patient of headache, so I have to ask the patient for blurred vision, also for nausea, vomiting, neck pain, and stiffness. You see, if I have patient of chest pain, I have to ask for shortness of breath, for sweatiness that indicate MI. So associated symptoms, it's different from symptoms to other. Then I will go to the involved system. So in our scenario, the involved system is GI system. So I have to ask in details for other symptoms in this system. So I will start from the mouth. I will ask the patient, do you have any sores in your mouth, any dryness in your mouth, any acid test in your mouth, any difficulty of swallowing, any pain when you swallow, you see? Any epigastric pain and any stomach pain, any heartburn, then any change in bowel habits. Ask for stool character. Ask the patient if there's any change in the stool color, if there's any change in the stool form, is it offensive, is it difficult to flush. Ask if there's any blood, any phlegm, any mucus. It looks greasy stool. So you have to ask in details, then go to the liver. Liver is considered a part of GI system. Ask the patient, do you have any yellowish discolorations of your skin and the back of your eyes? Ask or white of your eyes. Ask him if there's any itching. Itching is very important. Any abdominal distension, tummy distension that could indicate ascites. So in this way, I will ask in details for all symptoms related to the involved system. If you have patient presented with headache, so I have to ask in details for other CNS symptoms. So it depends on your scenario. After that, I will go to my differential diagnosis. So what are differential diagnoses? I put it outside. I put in my differential diagnosis that could be peptic ulcer disease. So I will try now to ask the patient if there's any risk factors of peptic ulcer disease. I will ask about it to get the diagnosis. I put in my mind that could be irritable bowel syndrome as a differential diagnosis of abdominal pain. I put in my mind that this could be an inflammatory bowel disease as a differential diagnosis of abdominal pain. So I will ask now about that. Then I will go to the systemic review. So I will try quickly do a systemic review that sometimes can help you to get the diagnosis. And to make it easy, start from the head to toes. So for systemic review, start from the head to toes. Ask 2 or 3 questions related to each system. So I will start from the brain. I will ask the patient, there's any headache, any limb weakness, any abnormal sensation. You see? What about your walk? Is there any problem in your walk? Any blurred vision, any double vision, any gritty eye or redness in the eyes? You see, I will go to the face. Do you have any asymmetry in your face, any skin rash in your face when exposed to the sun? Then I will go to the neck. In the neck here, very important to ask for thyroid symptoms. It's very important. Don't miss it. Then I will go to the chest. I will ask for cardiac symptoms, respiratory symptoms. Then I will go to the abdomen. In general, I will ask for GI symptoms and also for kidney symptoms. For kidney, only it's enough to ask the patient 3 questions. There's any change in the amount of the urine, any change in the amount of urine, any frothy urine, any blood with your urine. Okay? Unless your case relate to the kidney disease, that time I should ask in details. Then I will go to the lower limbs. I will go to the lower limbs. So what I should ask in the lower limbs? In general, we're asking for proximal muscle weakness. Do you have difficulty to get up from chair? Then ask for joints, because you see, go back down, so you will see the knee joint. So I will ask now for joints. There's any joint, any stiffness, any tightness in the skin, any skin rash in general. Then for legs, ask the patient in general if have ever before has history of clots in the legs. Then you have to ask the patient for anemia symptoms. It's very important. Make it habit to ask the patient for anemia symptoms. That anyone comment that you look pale? Do you feel dizzy when standing from lying to upright position? Do you feel any shortness of breath on exertion? Do you feel tiredness? Then for woman history, if your patient is female patient, so you have to ask in details for woman history. You have to ask the patient for hair period, whether regular or irregular, the volume, whether it's a heavy period or scanty period. Ask her if there's any chance to be pregnant now. When was the last delivery? If there's any complicated delivery, whether the patient taking any contraceptive method. Also ask her if the patient has any history of abortions. So you have for all patients to ask in details. Then for psychiatric symptoms, it's enough to ask the patient if there's any change in her mood recently. We'll go then to past medical history, past surgical history, then medication. Ask the patient what are medication you are taking it regularly. So first ask for regular medications. If the patient taking any medication, you have to ask now, when she start to take or when he start to take this medication, any change, any recent change of the dose, any new medication. So simply, The patient tell you, I'm taking losartan, I'm taking metformin, I'm taking Victoza. Is there any change in the dose recently? No, no, doctor. Any new medication? Yeah, doctor, I started Victoza only 1 month ago. You see? So it's very important to ask. Believe me, sometimes you can get the diagnosis only when you ask these questions. So you have to ask it. Then ask the patient for drug allergy, if there's any drug allergy. Also, it's very important to ask the patient any new vaccines. It's very important. There are some scenarios that you can get that scenario only when you ask the patient about any recent vaccines. There's some scenario related to the COVID-19 vaccines appeared recently and frequently. Also ask the patient if there's any medication, over-the-counter medication. If the patient taking any over-the-counter medication or traditional medication. Here also you can ask the patient if he's taking any recreational drug, but you have to be sensitive. Have to ask by sensitive way. Ask the patient, I'm sorry, I want to ask you one question. I'm asking to all my patients, do you take any party drug? Then for family history. Family history asks first if there's anyone in his family have similar symptoms. This first. Also ask if there's any family history of note in general. So for family history, we have to ask at least 2 questions. Any family history of similar symptoms, any family history of note. Because the patient could tell you, yes, doctor, my father has like this pain, but he deny any other family history if you don't ask him. And the patient could have family history of lung cancer, as example. But if you don't ask him any family history of note, he will not answer him. He will not answer you. Okay? Then we'll go to the social history. Start by asking for smoking, how many cigarettes, over how long. For any patient who is smoking, whatever the amount of smoking, 1 cigarette, 2 cigarettes, 20 cigarettes, advise patient to stop smoking, tell him that it's hazardous for his health, and refer him to smoking cessation clinic. So whatever the patient tell you, doctor, I'm smoking 1 cigarette per day. Mr. Sommer, smoking is dangerous for your health. I advise you to stop smoking, and I can help you by referring you to smoking cessation clinic. So counsel him for smoking in this moment to don't forget it. Then for alcohol drinking, ask also direct questions. How many units of alcohol do you drink in the average of week? Most patients can answer these questions. Some people could have no idea how can calculate the units and could tell you, yeah, doctor, I'm drinking every day 1 glass small. So that time you can ask that whether it's a small glass, moderate, large. It's right. It's important. So now for alcohol, if you find that patient taking recommended amount of alcohol that it's 14 units or less, and the patient has no diseases, no symptoms related to alcohol, so no need to counsel him about alcohol. So if the patient taking the recommended amount of alcohol with no any symptom related to alcohol drinking, no need to counsel him about alcohol. If the patient exceed the recommended amount, you have to ask him to also moderate his drinking. Now, if the patient drink alcohol, but he has something related to alcohol drink, like polyneuropathy, like pancreatitis, like liver disease, you have to ask him to stop alcohol gradually, whatever the amount of alcohol, even if 1 unit only. This for alcohol drink. Then ask the patient for long-term relationship and family support. Ask if he has any partner. Don't ask him, are you married? So are you in long-term relationship? Job, what's your job? Then ask for travel history. Driving, if applicable, if the patient has loss of consciousness, loss of vision, you have to ask for driving. And HIV risk. For HIV risk, the preferable questions to ask the patient if there's any unsafe, unprotected intimate relationship. So that the preferable questions. Anytime, have you ever You see, asking this way, have you ever before has unsafe, unprotected intimate relationship? Also, you can ask for any tattooing, any also blood transfusion abroad, any dental or surgical procedure abroad, that all can increase the risk of hepatitis and HIV. Then we'll go to examine the patient. Start first with a general examination by examining the hands, looking for any deformities, any clubbing, any cyanosis, any palmar erythema or paleness. You see? Then check the pulse. I advise to make it a habit to check the pulse in both hands. Make it a habit. Because if you miss sometimes to examine the pulse in both hands in scenario suggestive of Takayasu, you could lose the scenario. So what this advice to examine to make it habit in general to check the pulse in both hands. After that, I will go to examine the eyes. I will check if the patient has any evidence of anemia and jaundice. I will go to the neck. I will check if the patient has any lymphadenopathy. This is the general examination that should be done in all patients. Then I will go to the target examination. So what I did right in my paper outside, I wrote abdominal pain for examination. So here in this scenario, the target examination should be abdomen. Please don't go to examine the lung before to examine the abdomen. Don't go to examine the heart before to examine the abdomen. This will affect your performance significantly. Believe me. So here I have patient of abdominal pain. I will go to the abdomen. I will follow the same step of abdominal examination in the abdomen station. I will see first, check for any pain, ask the patient if there's any pain now, take permission. If he has pain, tell him my examination could be painful. I will try to be gentle. Please, if you feel any pain, please to tell me. Okay? Then inspection, see if there's any abdominal distension, if there's any scars, if there's any extended veins in the abdomen. Then you can start with by palpation, and while you palpate the abdomen, try to look to patient eyes to check if there's any pain. Then examine if there's any organomegaly, examine the kidneys if are palatable or not. Also, you can auscultate the abdomen. Sometimes you need to tell the examiner that I will do digital rectal examination. Sometimes you have to ask the examiner. In this scenario, yes, I prefer. In this scenario, I prefer to tell the examiner that I will do digital rectal examination. Yes. So this how can examine. Then you can go to the other involved system. Please try to don't examine any system not related to the presenting symptoms. Some doctors, some examiner will consider it irrelevant examination. And this happened. It happened. So this how can take a history and examine the patient. Let's now go to our case differential diagnosis of our scenario in general. Forget now this scenario. So what are differential diagnoses of abdominal pain? What are differential diagnoses of abdominal pain? Actually, differential diagnosis of abdominal pain, all of you know that broad, and we cannot summarize it in one lecture. In general, the differential diagnosis of abdominal pain depends which area affected. If the patient has right upper quadrant, so it could be liver, could be gallbladder. If it's epigastric, could be stomach, like peptic ulcer disease, pancreatitis, pancreatic cancer, or sometimes could be MI. That's right. So MI, especially inferior MI, the patient could present it with epigastric pain. If the patient has left upper quadrant pain, that could be spleen or could be pneumonia. Some patient of pneumonia could present with left upper quadrant pain. Right iliac fossa is very important. For any patient presented with right iliac fossa pain, you have to consider Crohn's disease, even if the patient has no change in the bowel habits. It's very, very important. Appeared in the exam many times. So we know that Crohn's disease, the main complaint is abdominal pain. Is that right? While in ulcerative colitis, the main complaint is change in the bowel habits, bloody motion, bloody diarrhea. So what I need you to concentrate on unusual, uncommon causes of abdominal pain that appear frequently in the exam. First, acute intermittent porphyria. It's very common in the exam as a case of abdominal pain. Acute intermittent porphyria. The patient usually presented with abdominal pain that could be severe, constipation, neuropsychiatric symptoms associated with the neuropsychiatric manifestations like pure motor polyneuropathy, depression, or seizures. The acute intermittent porphyria is an autosomal dominant disease. So the other family members could have similar symptoms. Patient of acute intermittent porphyria also can report a change in the urine color, especially when exposed to the light. So in general, put it in your mind that common and appear frequently. Second, that's very common, familial Mediterranean fever, when the patient presented with abdominal pain along with fever, and also pleuritic chest pain, joint pain. Also, it's a family disease, it's autosomal dominant, and other family members could have similar condition. 3, angioedema. Angioedema, the patient could be presented with only abdominal pain or could be presented with abdominal pain along with facial swelling or swelling affect other area. You see, it's not necessary for people of angioedema to have facial swelling. The patient could have a swelling in his hands, could have swelling in his legs, or could have a swelling in the private area. So you have to ask the male patient if there's any scrotal swelling or in female patient if there's any private area swelling. Angioedema can suspected if the patient taking any medication can cause angioedema, like ACE inhibitors and NSAIDs. Also, if there's any family history of angioedema. 4, polyarthritis nodosa. Also, it appeared frequently as a cause of abdominal pain. The patient, polyarthritis nodosa is a vasculitis, right? So the patient could have other manifestations of vasculitis like joint pain, skin rash, and also neuropathy. Could be mononeuritis multiplex or polyneuropathy. It's common in patients of hepatitis B. It's more common in patients of hepatitis B. Then Addison disease. Addison disease, really the abdominal pain starts early in the disease course of Addison disease. So the patient also presented with abdominal pain, skin pigmentation, also orthostatic dizziness due to postural hypotension, a feeling recurrent dizziness, and also tiredness due to hypoglycemia. Then other differential diagnosis could be inflammatory bowel disease, as we know that the patient could have change in the bowel habits, bloody motion, irritable bowel disease, and also could be renal calculi. Could be pyelonephritis. So there are many differential diagnoses of abdominal pain that it's very important to consider it one by one. Any question, please?
Sir, can you just repeat for acute intermittent porphyria?
Yeah. So the patient of acute intermittent porphyria usually presented with abdominal pain along with constipation. The patient has neuropsychiatric manifestations like not necessary to be all, but could be pure motor neuropathy, depression, or seizures. Also, there is change in the color of urine when exposed to the light. That looks like red color. It's an autosomal dominant disease, so other family members could have similar condition. And the rule here, doctor, that patient of acute intermittent porphyria has recurrent episodes of abdominal pain with misdiagnosis And it's common that patient underwent abdomen surgery for looking for any cause of abdominal pain. Really, it's very common before to get the diagnosis. The similar thing in patient of familial Mediterranean fever. It's very common to see like this patient underwent more investigation, like sometimes surgery for appendicitis or abdomen surgery, only searching for what could be the cause before to get the diagnosis. So the patient usually have recurrent episodes of abdominal pain. Any question, please? Yeah, this is also Dr. Marina asked that what the cause of numbness in this case. Yeah, great, doctor. So this patient has diabetes for 10 years, and you see that this patient has complication of diabetes, and this is very important because also Dr. Noor missed to ask me about that. So here the patient has first a diabetic neuropathy, as this patient has numbness affect his feet. The patient has diabetes retinopathy, as the patient underwent laser therapy. Also, if you ask me in more details, this patient has diabetic nephropathy. How can you know it? So, when you have a patient of diabetes, you have to ask in details if the patient has any complication, either macrovascular or microvascular or hypoglycemia. So what are macrovascular complications? Ask the patient if there's any heart attack before, any stroke or mini stroke, any peripheral vascular disease by asking, do you have any pain in the back of your leg when you walk? Then for microvascular, that it's retinopathy. Ask the patient, do you have any blurred vision? If no, ask him, do you follow regularly with the eye doctor? Yes, doctor. Did he tell you that any change in your eyes? You see? Now, for nephropathy, ask the patient, there's any change in the urine amount, any frothy urine? If the patient deny, so ask him, did you check your kidney functions regularly with your doctor? Did anyone tell you that there is protein in the urine? You see? Because the earliest sign of diabetic nephropathy is proteinuria. So did anyone tell you that there is a protein in the urine? This way. For neuropathy, you have to ask for motor, any weakness, sensory, any abnormal sensation, autonomic neuropathy. By asking the patient, do you feel dizzy when standing from lying to upright position? If there's any early satiety, do you feel full just eating food? If there is any impotence in male patient, you see? And ask for hypoglycemia. This is how can ask this patient. So in this patient, to know that it's a complication of diabetes, you have to confirm other complication. Any question? Yeah, and also doctor ask if there's any tummy trauma. Okay. In general, whatever the site of pain, try to ask for trauma. Whatever the site, headache, chest pain, abdominal pain, back pain, make it habit. Any source of pain, you have to ask for trauma. There are many scenarios appear nowadays related to trauma. Any question, please? Yes, it's important. So these questions. So if the patient diabetes, so I have to ask for complication. Yeah, you have to ask for complication, doctor. So when your patient tell you, doctor, I am diabetes, so you have to ask him, when was diagnosed as diabetes, whether controllable or not, the last HbA1c, ask him what are medication he's taking, his compliance to medication and also diet, and then ask him for complication, as I have mentioned, macro, micro. Yeah, it will take time. Yes, I'm sure it will take time, but this also can help you. So now when I know that this patient has diabetic neuropathy, and the patient presented with a change in the abnormal renal function test. So I cannot know that this is diabetic nephropathy. Again, and if you have a scenario that patient presented with abnormal renal function test outside, and you discover that this patient has diabetes, so to know whether this abnormalities in the renal functions relate to the diabetes or not, I should see if the patient has another complication, because it's very rare for the patient to have only diabetic nephropathy. So the patient will have another complication like retinopathy, like neuropathy, like microvascular, like stroke, heart. You see? Yeah, it's important, doctor. Any more? So thank you very much for attending this session. Actually, as you know that next month will corresponding with Ramadan month, so it's difficult to doing any session, but I will try. I will try to do at least one session in Ramadan, inshallah. I will try the best to do one session in Ramadan, inshallah. I will send the announce for that. Thank you very much for attending. I will send the recording to the group tonight about 10 o'clock. Thank you very much. Assalamu alaikum wa rahmatullah.